Now with the next case, Dr. Mona Kamel, she's lecturer in our Cairo University. She will present case number 3.
Good afternoon. Our third case, a young patient, right-handed with negative febrile conversion, but positive family history of epilepsy. His mother being epileptic after brain surgery, lipoma resection, and negative perinatal history and normal development. His seizure started at the age of 12. He described it started with a frontal sense of heaviness and headache, followed by impaired awareness and right upper limb dystonic posturing, left upper limb automatism with gyratory movement turning around himself to the left, with post-ictal nose wiping, but by history, they couldn't lateralize to a certain side. Infrequently evolved to bilateral tonic-clonic. His seizure frequency was twice per week, diurnal mainly. He was on 3 anti-seizure medication, levetiracetam, 2 gram per day, oxycarbamazepine, 1200 milligram per day, topiramate 100 milligram per day. This is a home video. He recorded during his work. He started.
Which one's the patient?
Sorry.
There's lots of people.
This one.
I think the patient is the one taking the video, right?
This one. This one. He started with arrest of behavior this second, and he started with the pushing and turning around himself. Sorry.
Now we know.
As you can see, the pushing of his right upper limb and turning around himself. And this is the end. Would you like me to play it again? Okay.
Now that we know which person it is. This was a trick. Which one is it? This is an exam.
This one. And he started. Arrest of behavior. Then pushing and turning around himself twice. Okay. I have another video, but it showed that it's late. Recording was late, and that he evolved to bilateral tonic-clonic. They are covering him. Okay. This is regarding semiology. Would you like me to play it again or anything? We're good. Okay. His examination was normal, and now we will play the EEG.
The patient has done 2 long-term EEGs, total of 2 seizures, 1 in each record. Interictally, he has very frequent, abundant left anterior temporal spikes and sharp waves, and also slow waves. The seizure that occurred during the record It was out of sleep. There is, as I can see, there is a buildup of rhythmic activity in the left um, frontal and also temporal region. Do you want to see anything else or any montage, other montage?
It's helpful to go to the onset of the seizure.
I'm sorry.
We need to go to the onset of the seizure because it's the
This
first.
is he was sleeping, and this is with the artifact.
Yeah, but you need to always go 5 seconds before.
Yes, this is 1 second. I will go
Yes,
a second.
always go 5 seconds before where you think it starts.
Okay. There is these abundant interictals that were there. Okay. The record has very, very abundant interictals, and also dysrhythmia in the left anterior temporal region.
He's also got focal slowing in that.
Yes, he has. Yes, he has slowing and dysrhythmia and abundant interictals in this region, in the anterior temporal region. Now we are going towards the seizure.
So, where do you think the seizure begins?
I mean interictally, or you mean this is the clinical onset?
No, where do you believe electrographically the seizure
I
begins?
assume here, this in this artifact.
I think it's 3 seconds earlier.
Agree.
So there's an attenuation of the recording.
Yep.
Another 2 seconds before. You need to, if you change the time course to not the time constant, the display time to 15 seconds. Okay, and then if you go 1 second, 1.5 seconds before where the green line is.
Forward or forward?
Backwards in time.
Backward.
No, just. Okay, so now right there. So there is a large slow wave with attenuation of the recording that phase reverses at T3 that then evolves. I would argue the seizure begins there rather than 3 seconds later.
Okay.
Part of the challenge is there's so much interictal abnormality that it could be easy to confuse them. But I think you have some rhythmicity underneath that then the person arouses, and then you see the more rhythmic theta activity in the temporal and central region.
Okay.
I agree.
Proceed to the imaging.
Should be in the right hemisphere. That's what I'm saying. It's probably going to be a right hemispheric leader now.
So you said he wipes his nose. What hand does he wipe his nose with?
The family couldn't recognize which side, unfortunately.
There you go.
So nice. The problem here is that we have
a duck.
Yes, 3 ducks.
I agree with that duck.
3 ducks. So here you can find the amygdala and the pool. The left side is blurred, and the volume is rather increased, and the hippocampus on the left side, and I think in the left insula also here. But we have another problem. Is the right hippocampus. There is a little bit of a signal here on the head, and we can see it on the T2, and maybe a little bit of volume loss.
Do you know how soon after his last seizure this MRI was taken? How often is he having seizures?
Twice per week.
Once a week?
Twice per week.
Twice a week?
Yes.
So post-ictal hyperintensity is pretty well known, and it
Yes.
can give you the false signal of like a bilateral temporal lobe disease, and all what it can be simple bilateral spread.
Okay.
So I didn't see anything at least from the few pages that we looked at from the EG. I didn't see anything from the right side. To my eyes, the hippocampus looks nice. It's a little bit hyper intense signal, but I see nice amount of float around it. It does not look sclerotic to my eyes. It's all on the right. I'm sorry, on the left side too.
Yes.
What I think, yeah.
So the left is more.
Yes.
We have a lot of on the left, and we did PET. Do you want to see it?
Sure, if you did
Okay.
it, might as well.
Now it's on the left side.
Yeah.
So
Yes.
you know, when you have a lesion like that, the PET scan is not likely to contribute additional information. You've got a large abnormal lesion, and so the PET scan is going to be abnormal over it, and the abnormalities you see that you may or may not be able to relate to anything else, but it gives you pretty pictures.
Okay. So what's next?
What do you want to do?
Is he a candidate for resective surgery?
Excuse me?
Resective surgery?
Do you have any other images of the insula? I mean, if you're concerned about the insula, then that gets you into other issues, but
You want to see the insula?
do you have a? I mean, sometimes the flare is deceptive. So do you have T2 images?
Yes, here. You can see it.
Well,
So yes. So comparing thicken. What do you think? Some signal? So what do you think?
Okay, I'll take a stab at it.
Yeah.
So you have very stereotypic cedar semiology, and the EG is showing you the same exact signature every single time. The patient's drug resistant, and you do have a lesion in the MRI. The question becomes, I have some insular or some mesial temporal, in addition to that, lower temporal, inferior temporal lesion. So the question becomes, is the focus or the seizure focus coming from that exactly where your arrow is coming, or is it coming from the insula? So is that a simple T2 hyperintensity from the spread or not? So the answer is yes, epilepsy surgery can really cure this patient. The question becomes, where do I resect and how do I resect? To do it right, a large or multi-lesional epilepsy, I treat it as exactly as a non-lesional epilepsy, meaning that I'm going to need to at least sample and make sure that I put electrodes in all the abnormality that I see on the left side here to do it right. Then to be 100% certain, the best way to do it is a two-stage. You implant, you capture seizures, and you go in with 100% slam dunk. You're not wavering 80-90%. The next best from that is a single stage, and you go after the area with the highest interictal spikes. You're not going to get a seizure in the middle of the operating room, so you go with that. But that's the next. That's option B, which is not as good as option A. Okay. But I'm interested to hear what my colleague might say here.
Yeah, there are three things you can do. I agree with everything you said. You can take out the big lesion. I mean, stereo EG is going to give you more confidence in what you should take out in a single procedure. Option two is to take out the big mesial lesion, see how the child does, and explain to the family there's a 20% chance you're going to need to go back. But at the end of the day, if both are abnormal, then both are likely going to generate seizures. So I think at the end of the day, you're going to need to take both out, and taking out the insula is not easy. I think the safest thing for the child is to take out the mesial lesion, see how the child does, but be ready to go back to go after the insula.
I mean, the only other thing that I would say is you've got fairly broad impairment in the psychometric testing, right? You've got attention issues, you've got verbal and visual memory impaired, you've got some language impairment, you've got flexibility. The trail's making A and B at the bottom. I call it the fancy dot to dot. So it's 1A, 2B, 3C, 4D, 5E.
Exactly.
He can't do any of that. And what I don't know, and I don't know if you have this from the history, did he have, before the onset of his seizures, previous levels of impairment like this?
Sorry?
Was he before he had the onset of seizures, was he this impaired across the board? Was he always a low functioning child in all domains?
Actually, he was assessed recently, not before the seizures. So we don't know baseline at the start of epilepsy. But his impairment was more prominent regarding verbal memory compared to the visual memory. Visual memory is slightly impaired, not significantly impaired. But his attention and difficulties in executive functions, I was attributing this due to he is on already topiramate in a high dose, so it led to his delay in performance in a lot of tests, and he needed repeatedly to keep his attention with me during the assessment. But his IQ was just below average; it's not very severely affected.
Okay.
So, would this be of value in our decision?
Then it's less so if he's on high doses of all those meds, but he's not functioning normally right now. Yeah.
Verbal memory.
So I agree from probably functional standpoint, but will it cure his seizures and epilepsy? That's the question. So I think I totally agree with you. Ideally, like we discussed, best thing is to do bilateral recording. I'm sorry, in both lesions. If that's not an option, if that's not available, and the family is okay and understanding, there's probably, I don't know, 60-70% chance it might cure the seizures. But if not, there might be a second operation to go in after. So all what it is, what's the likelihood of making him completely seizure free with a single operation? What you said is perfectly fine. I think it makes perfect sense. But will it guarantee a high resolution of seizures? I don't know without the recording. Yeah. How about this? Just maybe option C here.
Take out the right brain.
No, not. Really got his seizures under really good control, whatever it takes, and repeat an MRI, because I still will put a question mark. How much of that is post-ictal changes as opposed to actual underlying dysplastic tissue? So I would get his seizures really, because I think we might end up going back to that mesial temporal structure, because that's probably where most of the problem is. I just got to resolve what's the insula doing. How much of that is actual abnormality as opposed to post-ictal changes. Yeah, I know we don't have RNS in Egypt, but that would have been a very nice, easy. Stick two electrodes, one in the mesial temporal, another one in the insula. I'm done. Everybody's happy, and we move on.
And the seizures will not be controlled. Take out the lesion.
Come to my center. I'll control that. Promise you.
The safest thing you can do is take out the mesial lesion, see how he does, and then go after the insula lesion, because the insula resection carries significant risk.
I agree. So practically here today, what's not an option is to continue what he's doing. That's not an option. That's out of the question, right?
Yes.
Next best thing, let's go after that mesial temporal structure. Get with the good understanding from the family that this will have a high likelihood of clearing seizures, but not 100%.
Okay. Great. Thank you.